אני שמח מאוד לפתוח את הכנס העשירי, את הכינוס העשירי של פורום ראש צוואר של הצפון. אני שמח לראות חברים כל בתי החולים של הצפון, גם נהריה, כרמל, הגיעו חבר'ה מפוריה, בני ציון, מנצרת, מי עוד? זיו. יופי. אז אני בטוח שיהיה ערב מענה, ובגלל שיש לנו תוכנית מעניינת עם אורח שעוד מעט דוקטור בלן יציג אותו, ואחרי זה מספר מצגות שהגיעו מיטת החולה לכאן כדי לקחת החלטות. אז כמו שאמרתי, זה הכנס העשירי. רק קצת בריפינג על מה שעברנו עד עכשיו. אתם רואים פה דוקטור דואק שלנו סיכמה את כל 10 הכנסים. היה לנו אישו ראשון שדוקטור כהן ודוקטור בלן הובילו על הרינגל קנצר. After that, Jayton Shah was with us. Other people that were invited, the keynote speakers, were O'Sullivan, Joe Califano, Ezra Cohen was a couple of years ago, and we actually trying to continue with our tradition with 2 events like this per year, and that was not possible without the help and support of the companies, MSD, which support us, and AstraZeneca, which also helped to sponsor this event. And I want to invite Dr. Balan to present Dr. Ezra Cohen.
שלום לכולם, ואני שוב מודה לחברת MSD וחברת אסטרהזניקה על זה שתומכים בנו תמיד להמשיך את המסורת ולעשות את הכנסים האלו שאני חושב שהם מאוד מאוד חשובים. It's really my pleasure to introduce Ezra, Professor Ezra Cohen. He's a friend of us. This is the second time that we will have here and will be many times, I hope, in the future. Professor Ezra Cohen is a co-director of the Center for Precision Immunotherapy. He has been acknowledged for his contribution to the National Cancer Institute Task Force of PI3 kinase AKT-mTOR targeting. Dr. Cohen led to an independently funded laboratory interested in mechanism of action of novel therapeutics. He has made major contribution to targeted therapy. His recent National Institute of Health funded work in the study of epidermal growth factor receptor inhibitor in head and neck cancer has contributed to the understanding of the biology of this critical signature network, integration of this agent into standard of care, and definition of mechanism to overcome resistance. He has recently appointed as a chair of the NCI Head and Neck Cancer Steering Committee that oversees NCI-funded clinical research in this disease. Dr. Cohen is Associated Director for Translational Science and Team Leader in Solid Tumor Therapeutic Research Program. He recently served as Editor-in-Chief for Oral Oncology, the highest impact specialty journal in head and neck cancer. He has been the principal investigator of multiple studies of novel agents in head and neck cancer and other solid tumor in all phases of development, including chemoprevention, phase 1, 2, and 3 trials. Dr. Cohen has researched at national and international meetings. In addition, he is chair of the Career Development Subcommittee of the American Society of Clinical Oncology and has served as a grant reviewer for NIH, American Association of Cancer Research, American Society of Clinical Cancer, and the Ontario Institute for Cancer Research. So it's talk today regarding the immunotherapy in head and neck cancer. Please.
תודה רבה. I'm not going to speak in Hebrew, so I apologize. By יום שני אני מדבר עברית, אבל עכשיו אנגלית. So thank you for the introduction, and thank you again for the invitation. As I was preparing this talk, I realized that all the slides are different than just 2 years ago. It just goes to show you how fast the field has moved in the last 2 years. Whereas we were talking about targeted therapy and chemotherapy 2 years ago, now the groundswell is immunotherapy, and it's really a pleasure to be able to come and present data on immunotherapy in squamous cell carcinoma of the head and neck, and especially to this audience. Immunotherapy is not a new idea. In fact, it's been around for more than 100 years. And really the first immunotherapy trial, if you will, was of a drug called Cooley's toxin. And that paper, if you can call it a paper, was published in the New York Times in 1886. And what Cooley's toxin essentially was, killed bacteria that was injected into cancer patients. Cooley was a surgeon in New York, and he took these killed streptococcal bacteria, he injected them into patients with sarcoma, and sure enough, in some of those patients he saw a response. Believe it or not, Cooley's toxin was available in the United States until about the 1960s. But the idea that inducing the immune system to kill cancer, as I was saying, was not new. The problem was that we had to learn how to do it in a way that would, in fact, induce the immune system, but would not kill the patient. And that's what we struggled with for decades. We had methodologies like interleukin-2 and interferon that clearly induced an immune response, a cytokine response, but they were toxic, and in fact, some of the toxicities were life-threatening. And I'll get to where we are now in terms of drug therapy for immunotherapy, but why are we excited about immunotherapy, and what are we really trying to achieve? And I like to illustrate it using this slide from a recent paper, comparing the different types of therapies that we have at our disposal. When we look at chemotherapy, what we see in almost every cancer is an improvement in survival, but very, very few cures. If we look at the Kaplan-Meier curves for chemotherapy, we see that the survival goes to 0 in almost all cases, with some rare exceptions, of course, testicular, germ cell cancers, some leukemias, but certainly for solid tumors, the curve goes down to 0. For targeted therapy, what we've seen is that the curve shifts, so we're able to extend life by targeting EGFR tyrosine kinase mutations, HER2 amplifications, but for the most part, with again very few exceptions, we've shifted the curve, but the curve goes to 0. Oh, I see you don't. The mouse doesn't show up, but you'll take my word for it. Oh, is this a pointer? Yes. Oh, so the curve shifts, but the curve goes to 0. What we're beginning to see with immunotherapy is that although the curve isn't shifting, the median overall survival is about the same, but we're beginning to see a tail on the curve. And I'll illustrate that with real-world examples. The promise of immunotherapy is that we can shift the curve, that there will come a day in almost all tumors, if not all tumors, where not only do we shift the median overall survival, but we actually increase the number of patients that are cured with immunotherapy. Well, in order to do that, we need to begin to understand the immune system a lot better, and we're beginning to understand the immune system. I like to show this slide because it helps encapsulate or categorize the immune system in a way that makes it targetable. Of course, it's a lot more complex than this, but if we think about it as a stepwise process that is a cycle, the first thing that has to happen is the immune system has to recognize a cancer, usually through antigens that are presented through MHC. That recognition then has to go on to priming. The immune system has to be primed. This is so-called signal number 2 and signal number 3. The primed T cells now have to migrate to the cancer. Once they get into the tumor, they have to invade, they have to contact the tumor cells, and then, of course, eventually and hopefully, they release proteins that are cytolytic, and they kill the cancer cells. That itself releases further antigens, and that's why this becomes a cycle. That's what we're trying to achieve, and we've begun to do that in multiple ways, including checkpoint inhibitors. And I'll spend a lot of the next part of the talk talking about checkpoints. Checkpoints, of course, now are part of our regular lexicon, but what we have to understand, and it's important to understand, that these are physiologic mechanisms. And if you think about the immune system and what the immune system is meant to do, it's meant to actually protect us from mostly viruses and bacteria. And so what is the immune system supposed to do? It is supposed to activate very rapidly, eliminate the pathogen, and then go away. It's supposed to deactivate. And so checkpoints are really meant to do exactly that. Some checkpoints, oh, sorry, it's not coming up. You'll take my word for it. Some checkpoints are stimulatory. They're meant to stimulate T cells, and many checkpoints, including PD-1, PD-L1 interface, are inhibitory. They are meant to dampen the immune response once it has been activated. And so, that's very strange. What am I doing wrong? Okay. Oh, there we go. Okay. So in pink, you see the inhibitory checkpoints. In blue, you see the stimulatory checkpoints. And I guess I'll just use the keyboard. And so one of the first examples of a checkpoint inhibitor to work successfully was a drug called ipilimumab in metastatic melanoma. Now, melanoma, of course, as we know, is a special disease because melanoma has been responsive to immunotherapies for a very long time, and it's viewed as an immunoresponsive tumor. We're beginning to understand why that is, and it has mostly to do with the fact that it's a very high mutational load tumor, and we can talk about that if there's questions, but it's not necessarily the main point I'm trying to make. The point is that a single immunotherapy called ipilimumab that inhibited a checkpoint called CTLA-4 was more effective than standard therapy in metastatic melanoma. Well, we went from that to beginning to raise the curve. So I talked about how we want to increase the tail, and that's exactly what we saw in melanoma when we began to combine checkpoint inhibitors. In this case, ipilimumab, anti-CTLA-4, and nivolumab, anti-PD-1. And you begin to get a sense that the tail on this curve is shifting upwards. And now, for the majority of patients with melanoma, they can respond to combination immunotherapy. Well, with that in mind, we now have the next big step in immunotherapy, and that is extension of this efficacy to diseases beyond melanoma. As I said, for a long time, it used to be immunotherapy worked in melanoma, maybe in some patients with renal cell cancer, but really nothing else. But now, for the first time, we begin to see anti-PD-1 checkpoint inhibition working across the board. Multiple solid tumors and some hematologic cancers as well. Here, of course, is squamous cell carcinoma of the head and neck, somewhere on here. If you can find it first, tell me. But, yeah, first one? Yeah, there we go, head and neck cancer. But I'll draw your attention as well to some cancers that are incredibly responsive to anti-PD-1 therapy, such as Hodgkin's lymphoma. And we can talk about why Hodgkin's lymphoma is of particular interest if there are questions. But the point being that there's extension across a wide variety of tumor types with a single drug that inhibits a single checkpoint in the immune system. So with that in mind, what about single agent versus chemotherapy now? That really is the next step. If immunotherapy works in patients who are refractory to chemotherapy and other interventions, is it actually better than immunotherapy? And we got the first hint that the answer to that question, better than chemotherapy, we got the first hint that the answer to that question might be yes in non-small cell lung cancer just a few months ago at ESMO, originally presented and then published in the New England Journal of Medicine. And what this group of investigators did was they took patients who were felt to be especially responsive to anti-PD-1 therapy, and that is patients whose tumors expressed very high levels of PD-L1. And we can talk about other biomarkers, and I'll give you some hints at other biomarkers in just a second. But a group of patients with very high expression of PD-L1 and randomized them to either pembrolizumab, an anti-PD-1 antibody, versus standard of care chemotherapy, the standard of care for the last 20 years, and sure enough, improved overall survival dramatically versus chemotherapy in first-line non-small cell lung cancer. So now, what about head and neck cancer? We're here to talk about head and neck cancer, and I'll spend the rest of the time talking about it. We, of course, know a lot more about the biology of head and neck cancer, even than we did 2 years ago, and certainly than we did 5 years ago, 10 years ago. These are data from TCGA, the Cancer Genome Atlas, published on sequencing of about 500 squamous cell carcinomas of the head and neck, realizing a couple of things about this data set. First of all, these were patients with locally advanced disease. These were not patients with recurrent or metastatic disease. So a little bit of a departure from where especially the anti-PD-1 agents have been tested. And the majority of patients were HPV negative. So with those two caveats in mind, let's look at, I'll draw your attention to the middle, and what we can see is that there is a sizable proportion, about 10% in both groups, that actually deregulate the immune system in a way that would not be able to present antigen to the immune system. In other words, when HLA is mutated, or when B2N, beta-2 microglobulin, is not expressed, the immune system would theoretically have no way to detect that cancer because the antigen-presenting machinery is dysregulated. I'll tell you why that might be important in just a few minutes. But beyond that, we've also known for a long time, and especially in HPV-positive cancers, I'll show you the data actually in just a moment, that the immune system has responded to these cancers, but has clearly not eliminated these cancers. So there may be things that we can take advantage of. Along the lines of TCGA, the other thing to note is the mutational load in head and neck cancer. I referenced mutational load just a few minutes ago talking about melanoma, and what we've come to realize is that the number of mutations inherent in a cancer is important to the immune system. And why might that be? Well, I talked about neoantigens, and the first step in that cancer immune cycle is antigen presentation to the immune system. If you think about every mutation in a cancer as an opportunity to produce a neoantigen, something that the immune system should never have seen because it's a product of a mutated gene and therefore a mutated protein or an irregular protein, the more neoantigens you have, the more opportunities there is for the immune system to detect that cancer, the more opportunities to be activated against that cancer and eventually destroy that cancer. It turns out that the most highly mutated cancer we know of is melanoma. And lo and behold, melanoma is a cancer that has been traditionally responsive to immunotherapy. The second most mutated cancer is non-small cell lung cancer. And I just showed you the data for non-small cell lung cancer with pembrolizumab. Well, if we look at head and neck cancer, it's about in the middle. It's not very highly mutated, but it certainly has mutations. And what we learned from TCGA, I'll draw your attention to the top of this. And this is HPV positive right here. These are all HPV negative for the most part. And what we see is that in the HPV negative, we have some patients with a lot of mutations, very high mutational load, represented by these spikes. But HPV positive patients also have a fair number of mutations. We used to think that actually HPV positive, because it was driven by the viruses, did not have inherently a lot of mutations. It turns out that that's not necessarily true. HPV positive cancers I would classify as moderate in their mutational load. And we can talk about why that is. That has to do with mostly the APOBEC machinery being dysregulated. With that in mind, let's focus for a second on PD-1 and PD-L1. And these are recent data from the Ohio State group showing that both HPV positive and HPV negative cancers express PD-1 and PD-L1. HPV positive cancers a little bit higher than HPV negative cancers, but there is expression there telling us that the immune system, at least for a large proportion of these cancers, has detected them. It's just not eliminating them. And so why would the immune system not be able to eliminate these cancers, even though it's recognized these cancers? And that, we think, has to do with a very immunosuppressive microenvironment. This is one example. This is from the Memorial Sloan Kettering group, Luke Morris, who looked at the same data set, TCGA, and asked about the expression of cell types. And what he found was that in many head and neck cancers, there's expression reminiscent of the presence of T regulatory cells. Of course, these are T cells that have an immunosuppressive phenotype. And in addition to that, when he correlated survival with the presence of T regulatory cells, as you might guess, the more T regulatory cells there were, the worse the survival. The opposite was true if he saw an expression pattern reminiscent of natural killer cells. The more natural killer cells there were, the better the prognosis. And so we're beginning to understand that the immune system has a tremendous influence on how a cancer behaves. Does this in fact translate into the clinic? And the answer obviously is yes, or I wouldn't be giving this talk. And we saw the first evidence in a study called Keynote 012. This was an expansion of a phase 1 trial using the drug pembrolizumab, an anti-PD-1 antibody, and lo and behold, it had single agent activity in patients with recurrent or metastatic squamous cell carcinoma of the head and neck who were refractory to therapy. And in some cases, these patients were multiply refractory, third, fourth, and in some cases even fifth line therapy, single agent showing responses to anti-PD-1. For those of you who aren't used to looking at these graphs, each bar represents a single patient, and the y-axis is the change in tumor size. And you can see for some patients, the change was dramatic. Green is HPV negative, red is HPV positive. So both HPV negative and positive patients appeared to benefit from anti-PD-1 therapy. But here's what's different than cytotoxic chemotherapy or cetuximab, the so-called swimmer's plot. Again, each patient is represented by one bar, and the length of time that they are on therapy is on the x-axis. And we are seeing patients on anti-PD-1 therapy who are exceeding, this is 60 weeks. I can tell you that in the updated data that was recently presented, these top patients are now more than 2 years, and this top patient is still on therapy almost 3 years after starting treatment. In fact, he is no longer on pembrolizumab because the trial stopped therapy at 2 years, and yet he continues to have a complete response. And I'll show you another example in just a few minutes. We don't see that with cytotoxic chemotherapy, at least not for the most part. We have seen it, but it would be very, very rare. What's exciting us about immunotherapy is not necessarily the response rate, but the duration of response. So with that in mind, can we begin to predict which patients are the ones that benefit? Unfortunately, the answer is no, but or more maybe. But what we can begin to predict are the patients that don't appear to benefit. And what I mean by that is that we're beginning to understand that you need to have an initial immune response, or your immune system has to have recognized that cancer and produced an interferon gamma response in order for an anti-PD-1 agent to work. And that's exactly what this shows. So this is a 6-gene signature done by nanostring, so on FFPE tissue. And it was further, it actually started as about a 70-gene signature, and it was further refined to 6 genes. And all 6 of these genes are interferon gamma related gene. I'll note that one of the genes is actually, oh sorry, it didn't make it to the last one. I was going to say one of the genes is PD-L1, but it's not on this list. But you can see that one of the genes is interferon gamma itself. The rest of these genes are all interferon gamma related genes. They're all expressed secondary to interferon gamma, and so is PD-L1. And what this group of investigators demonstrated, and actually now it's been demonstrated across multiple cancer types, is that if this signature is not present, the chances of response are almost zero. In other words, the negative predictive value of this 6-gene signature is about 95%. You have to have an interferon gamma response if you're going to respond to an anti-PD-1 agent. Keep that in mind because I think we can do something about that. Well, I showed you Keynote 012, which was an extension of a phase 1 trial. Did you have a question, Sal? Or? Yeah, so PD-L1 is transcribed in relation to interferon gamma. It is only expressed after interferon gamma is released. And so PD-L1 expression is is a surrogate marker for an interferon gamma response. So we had Keynote 012 in unselected patients with recurrent and metastatic head and neck cancer. Keynote 055 took it one step further, if we will. Now we have patients who were refractory to both cisplatin and cetuximab, again exposed to single agent pembrolizumab, as you can see in this schema. And sure enough, both HPV positive and HPV negative patients, you can see down here at the bottom, almost 50-50, and sure enough, almost the exact same response rate, about 18%. In fact, the paper was just published in JCO, and the response rate was about 18%. So despite the fact that now you have patients who are refractory to 2 standards of care in this disease, you still see the same response rate. So very encouraging data. I don't want to leave you with the impression that it's only anti-PD-1. Anti-PD-L1 seems to work as well. So this is a drug called durvalumab. Again, this was an extension of a phase 1 trial in a head and neck squamous cell carcinoma cohort. And sure enough, we see very, sorry, I didn't mean to go that far. Yeah, sorry. And sure enough, we see the same thing, about an 18% response rate. Interestingly, the response rate here, sorry, this is gone. The response rate here is higher in HPV negative. I think that's just the low numbers. My guess is that the response rate as the numbers get higher will be the same in HPV positive and negative. But I'll draw your attention to the PD-L1 high. 18% in patients who expressed high levels of PD-L1, only 8% in patients who expressed low levels. But having said that, there were clearly patients who benefited in both the PD-L1 high and PD-L1 low tumors. These are patients who appear to have had durable responses. So it's also anti-PD-L1. It looks like if you block the axis at the receptor or at the ligand, both mechanisms work and can work well for a group of patients. Now we actually have randomized data. So I've shown you expansions of phase 1 studies. Well, what about against standard of care? And we finally have that in Checkmate 141 with nivolumab versus standard of care in patients who were platinum refractory. So for the most part, second line recurrent or metastatic head and neck cancer. And what we saw for the first time ever in second line recurrent metastatic head and neck cancer is a positive study. So despite the fact that we have studied multiple agents in this setting, the first time ever we had an improvement in overall survival, and I would say a dramatic improvement in overall survival, with the hint that there may be a tail on this curve. Standard of care was methotrexate, docetaxel, or cetuximab. The investigator got to choose one of those 3 treatments, and that yielded a 1-year survival of 17%, exactly what we would expect from one of those drugs. Nivolumab, a 1-year survival of about 36%, a doubling of 1-year survival with a single immunotherapy targeting a single checkpoint in head and neck cancer. Almost all groups appeared to benefit or were on the favorable side of unity. And what's more, just like we saw in the other studies, the patients who expressed high levels of PD-L1, in this case the cutoff was just at 1%, appeared to derive the most benefit, suggesting again that you need to have an a priori immune response if you're going to benefit from these agents. Incidentally, the bottom shows you quality of life, and as you might guess, quality of life was also improved with nivolumab versus standard of care. But what can we do about the patients who have the response but are not actually have the immune response, so their tumors have recognized the cancer but are not responding? And to tackle that, or for that matter, what can we do about the patients whose tumors have not recognized the cancer whatsoever? And to tackle that, we've taken on a couple of strategies, and this is work from colleagues at UCSD. The first was meant to address tumors, the so-called cold tumors. I showed you that there's a group of head and neck cancers that have defects in the antigen-presenting machinery, and so therefore, their immune system, it would not be expected to detect these cancers because they're not presenting antigens to the immune system. Can we do something about that? And we think the answer is yes. And we attempted to do that with toll-like receptor agonists. For those of you who aren't immunologists, toll-like receptors are part of the innate immune system. They are evolutionarily preserved. Insects have toll-like receptors. Humans have a few more than insects do. But it's preserved through evolution, and what they are meant to do is to detect small pieces of RNA or DNA from pathogens that, upon ligation of the receptor, quickly activate part of the immune system, consisting primarily of white cells, dendritic cells, macrophages, and natural killer cells. We hypothesize that by injecting a toll-like receptor into the tumor, we can augment the immune response, especially with anti-PD-1, and that's exactly what we saw. But what the other important observation was not only in the injected tumor that you see here. This is, by the way, an HPV negative model. And as you can guess, when we inject tumors with this agent, which is a toll-like receptor 7 agonist, we see response where we're injecting the drug. But most importantly, we also see response in the uninjected tumor that is present on the other side of the mouse, suggesting that there is a systemic response to toll-like receptor 7, in this case 7 agonism, and that is augmented when we add the anti-PD-1. In fact, we saw the same in HPV positive. This is HPV negative. I'll show you HPV positive in a second. We saw the same with a toll-like receptor 9 agonist, and in fact you might argue that this response was even better than toll-like receptor 7, and we see the same in the HPV positive cancers. And without getting into too much of the detail, but I'm happy to ask questions, what we actually ended up seeing was the macrophages within the tumor and the uninjected tumor became antigen presenting cells and in fact began to present antigen to the immune system and recruit CD8 positive T cells. Exactly what we would want to do in a cold tumor. Moreover, we also recognized that head and neck cancer does have this immunosuppressive tumor microenvironment, and this is work by Judy Garner's group, looking now at a drug that might be able to reverse that microenvironment. What we've recognized, and what I haven't shared with you yet, is that in head and neck cancers, we often see an infiltrate of macrophages, so-called tumor-associated macrophages. If you phenotype these macrophages, they are the so-called M2 macrophage, an immunosuppressive macrophage. And it's characterized by expression of TGF-beta, IL-10, arginase, so very typical immunosuppressive cytokines. What Judy discovered was that the polarity of these macrophages is primarily controlled by a single pathway, a pathway that can be inhibited by, for instance, in this case, a single drug that targets PI3K gamma. PI3K kinase gamma is almost exclusively expressed in white cells, in myeloid cells, and it is highly expressed in these tumor-associated macrophages. Using either a knockout mouse, so Judy developed a mouse that does not express the kinase of PI3K gamma, or by using an inhibitor to PI3K gamma, what we see is that either in the knockout or in the drug, we can reduce tumor size. But when we combine that, as you might guess, with an anti-PD-1 antibody, we see almost elimination of tumors in HPV positive, and we see a dramatic reduction in HPV negatives. And what happens is a repolarization of the macrophages. We see a switch in their RNA expression from M2, immunosuppressive, to M1, immunostimulatory, and as soon as that happens, well, actually a few hours after that happens, we see a heavy infiltrate of CD8 positive T cells. Switch the macrophages, we do nothing else to the tumor, and we see an infiltrate of CD8 positive cells that now can destroy the cancer, and in the environment of anti-PD-1 can almost eliminate the cancer. And as you might guess, we're taking this now into clinical trials with these types of inhibitors. In fact, this also seems to be true in humans. This was part of the paper. We looked at TCGA and we saw the exact same thing as we saw in the mouse. We took the same signature that we used in the mouse and we asked, is it prognostic in humans? And the answer was yes. For humans who had a high M2 phenotype, this is the high M2 phenotype did much worse than the patients who had the low M2 phenotype, or presumably the M1 phenotype. This is head and neck cancer, this is lung cancer, the same was true in breast cancer and pancreatic cancer. So it looks like it's a phenomenon that cuts across multiple cancer types. So, as I said, we've taken both of these into clinical trials. Here is a trial with SD101, the toll-like receptor 9 agonist, and here is IPI 549, the PI3K gamma inhibitor. So what about real life? Does this actually happen in people? And now I'm sure there are many people in the room who can tell a similar story of patients that they've treated with immunotherapy. This, in a way, is a little bit of a special case because of the particulars of the individual. This was a 55-year-old gentleman who initially presented to another center in the Los Angeles area with locally advanced HPV-positive base of tongue cancer. Very typical presentation. You can see the lymph node involvement, you can see the base of tongue cancer, and because his career, his job, dependent on his ability to hear, he's actually a musician, he decided to get cetuximab instead of cisplatin. He did not want to risk ototoxicity. He completed therapy on time, no delays, everything went well. However, the post-chemotherapy radiation PET scan done about 12 weeks afterwards revealed not only residual tumor, but actually perhaps a worsening of the primary and now bilateral lymphadenopathy. Biopsy confirmed that indeed this was squamous cell carcinoma, so this was disease persistence in the face of full-dose chemotherapy radiation or biotherapy radiation. And now he was faced with the prospect of a total glossectomy and a pharyngectomy. He did not want to undergo that therapy, and so he asked his physician if there were any other possibilities and was referred to us. At that time, we had a clinical trial ongoing using pembrolizumab, so the same anti-PD-1 antibody that I've been talking about, with an IDO inhibitor called epacadostat. And IDO essentially is important to the livelihood of myeloid cells. And it actually catalyzes an enzyme that produces an amino acid that stimulates myeloid cells, and in the setting of a tumor, myeloid-derived suppressor cells. So inhibiting IDO is a way of theoretically stimulating the immune system. So he was able to get on the study. It combined pembrolizumab, as I said, with epacadostat, and the first scans done on May 10th, this was 3 cycles, so 9 weeks after he started, showed a dramatic partial response. What was really interesting about this case, and I'd be interested to see if you guys have similar experiences, we put him on the trial. About a week and a half later, he called me and he said, Dr. Cohen, the tumor is getting worse. I have more pain, I'm having trouble swallowing, and I think I'm progressing, and I think it's progressing rapidly. And I said, it doesn't make sense that the tumor would be growing this fast, this soon. Let me give you a prescription for opioids. As long as you're able to swallow liquids and maintain your nutrition, let's stay on the therapy. And if you have any trouble breathing, just call 911. Don't call me back, go to the emergency room. He called me a week later, about a week and a half later. This was before his second dose. Okay, so about a week and a half later, He says, Dr. Cohen, I haven't taken pain medication in 4 days. I'm now swallowing almost anything I want, and I swear to you, I think I just coughed up my tumor. And sure enough, this was the scan that we had on May 10th after 3 cycles. The next scan revealed a complete response of the tumor. Nothing, no PET avidity whatsoever. And now he was feeling terrific, functioning completely normally. His swallowing was almost back to what it was at baseline before the cancer. Well, this patient turns out to be Ricky Rocket, who some of you may remember the band Poison back in the 80s. So he's the drummer for Poison, who originated the band. In academics, there is no higher publication than People magazine. So once you get into People magazine, you know, your career is set. And so this was posted in People just a few months after he had the complete response. And I'm happy to say that he is now going on tour for the next 3 months across the United States and Canada with his band Poison, and which obviously would not have been possible a year after starting pembrolizumab and paclitaxel. And so that's a nice story. I would love to hear, you know, your stories of patients treated with immunotherapy. But let's begin to think about the future. And the future really lies in treating a larger group of patients, of course. And if we think about how well these agents are working in refractory disease, why shouldn't they work in first-line recurrent metastatic cancer? Especially when we realize that the 1-year survival with our current standard of care, that's the extreme regimen, is about 40%. I just told you a few minutes ago that single-agent nivolumab in second-line recurrent metastatic disease produces a 1-year survival of 37%. So one could easily hypothesize, and I know you're participating in some of these trials, one could easily hypothesize that these agents should be effective in first line and perhaps more effective than standard chemotherapy. Well, sure enough, those trials are ongoing. This is one example called Kestrel. Here you see durvalumab, this was the old name for it, as one arm of this study. A combination of durvalumab and a CTLA-4 antibody called tremelimumab, and the standard extreme regimen. Here you see Keynote 048, the same or very similar idea. One arm is pembrolizumab alone. Another experimental arm is pembrolizumab plus chemotherapy, which has shown good activity in other diseases, including non-small cell lung cancer, and the standard of care, of course, extreme. And then lastly, the other large phase 3 trial that's being undertaken is now nivolumab and ipilimumab, again, anti-CTLA-4 versus, again, the standard of care extreme. But if we are really going to make a difference in squamous cell carcinoma of the head and neck, we have to do it in locally advanced disease. Because not only do we now recognize that radiation can do positive things immunologically, radiation can free neoantigens, radiation can induce expression of PD-L1, and it can induce expression of MHC on tumors. Now, with that in mind, we also realize that for head and neck cancer, the great majority of our patients have locally advanced disease. In fact, 90% present with local or local regional disease. And as you might guess, preclinical data strongly suggests that radiation, given in the right way, and we should talk a little bit more about that if there's time, but radiation enhances the effect of anti-PD-1 therapy, and in fact, in this tumor model, eliminates tumors entirely. So there are trials ongoing. This is a phase 2 study that we're participating in using pembrolizumab with chemotherapy radiation. We presented the interim safety data last year in November. And what I can tell you is that for the first 28 patients, we did not see added toxicity. All patients were able to complete radiation on time. All patients were able to receive the full dose of cisplatin on time. Only 28 patients, but at least in those 28, it did not appear that giving pembrolizumab with chemotherapy and radiation had an adverse effect. Of course, it's too early to tell if we will improve survival, but at least it appears to be safe. The NRG, which is a cooperative group in the United States, has taken on a 4-arm study incorporating nivolumab into 4 different regimens in locally advanced disease. And then, of course, the Javelin trial, which uses a drug that I haven't discussed yet called avelumab, which is another anti-PD-L1 antibody being used in the context of chemotherapy radiation. Here, avelumab is given a week prior to starting, continued through chemotherapy radiation, and then given for 1 year after the end of radiation. And there you see the placebo control group. So with that in mind, let me leave you with a few thoughts. I hope I've shared with you the tremendous excitement about immunotherapy in cancer. And it's exciting for a number of reasons. For the first time, the data are being extended beyond melanoma. We're seeing responses in diseases that wouldn't be traditionally responsive to immunotherapy. And some of those responses are durable. It's predicated on a better understanding of the interactions between the immune system and the tumor. And we still have a long way to go. There's still much more we need to learn. But so far, we've been able to take that knowledge and translate it into therapy. It now represents a standard of care in multiple cancers, including squamous cell carcinoma of the head and neck, where the immune landscape is characterized by a moderate mutational load and a vigorous immunosuppressive microenvironment. Both of these we can take advantage of therapeutically. And then finally, as I said, PD-1 blockade is approved in platinum refractory recurrent metastatic head and neck cancer. And so thank you again for the invitation. Thank you for your attention. I think I went a little overtime, so I hope you don't mind, but I'm happy to take questions.